This presentation examines dual mobility bearings in primary total hip replacement from the 17th annual report. Dual mobility bearings were first used in the 1970s and combine the Charnley low friction principle with the McKee-Farrer principle of increased head to neck ratio. This resulted in a reduction in rates of instability, but there were concerns regarding accelerated wear of the polyethylene liner and intraprosthetic dislocation. Contemporary dual mobility has FDA approval in 2009 and uses newer polyethylene bearings with the possibility of lower wear. Proposed indications for dual mobility include total hip replacement for acute fracture and specific patient characteristics such as neuromuscular disease, cognitive disorders, and psychiatric problems, and anatomical considerations such as abductor deficiency, patients with small acetabular diameter, and fixed spinopelvic alignment. There's an overall risk of dislocation following primary total hip replacement in the UK of around 2 to 3%, although many of these patients will not go on to revision. However, in high-risk cohorts, the revision rate is up to 14%. The following are extracts from the 17th annual report. Dislocation and subluxation remains the leading cause of revisions within a year of primary hip replacement. Of the 37,400 single-stage revisions performed in the last 5 years, 18% cite dislocation and subluxation as a reason for revision. Dual mobility bearings are included as a separate category for the first time in the 17th annual report. They're described to contrast with standard unipolar bearings. They're categorized by the material of each part of bearing surface: metal on polyethylene on metal, ceramic on polyethylene on metal. Other combinations of dual mobility were too small to include as separate groups this year. This is a chart showing the type of hip replacement used over the last 16 years. When we look at dual mobility, rates were 0.35% in 2012, rising to 1.7% in 2019. This is a 5-fold increase, but the biggest increase has been seen in hybrid metal on poly on metal dual mobility hip replacements, with a 10 times increase. This is a Kaplan-Meier chart showing the cumulative revision rate in cemented hip replacements. Metal on poly on metal can be seen to have a much higher early revision risk, which then parallel with metal on metal beyond 4 years. Data is unreliable beyond 6 years on this chart. This is a Kaplan-Meier chart describing revision of uncemented implants, and the same pattern can be seen with a higher earlier risk and with data unreliable beyond 3 years. And finally, slightly different scale, but for revision of hybrid hip replacements, again, an earlier revision risk in dual mobility. So when we look at this chart showing the indication for hip revision, for the dual mobility bearing, there's still a reasonable number of patients having revision for dislocation, subluxation. But interestingly, there are much higher rates of patients having revisions for infections and periprosthetic fractures compared with other types of bearings. And this pattern is repeated when metal on poly on metal dual mobility bearings were used in hybrid and cementless fixation. So what are the possible explanations for this? This could be a case mix effect, with dual mobility mainly used in high-risk patients. Infection rates may be higher because of increased surgical time, possibly due to intraoperative conversion or unfamiliarity with kit, and the large head may be more likely to lie on skin edges before reduced. Periprosthetic fractures may be higher because of the torque created by the bearing, and possibly because of falls associated with bearing subluxation. Whilst poly wear leading to lysis may contribute to periprosthetic fracture, it's unlikely at this early stage. When we look at total hip replacements used to treat fractured neck of femur, we now find that dual mobility accounts for 8.4% of cases in 2019. 25% of all dual mobility bearings implanted during 2019 were used in neck and femur patients. This is a Kaplan-Meier estimate of cumulative revision in neck and femur patients with unipolar bearings in purple and dual mobility bearings in blue. As you can see, revision rates are similar. So in conclusion, the proportion of total hip replacements using dual mobility bearings has increased 5-fold in 8 years. Overall, there is a high risk of early revision when dual mobility bearings were used. Numbers are too small to comment on longer-term risks, and it is possible that there is a case mix selection effect. This early high rate of revision was not observed where dual mobility was used for patients with fractured neck and femur. Dual mobility will be continued to be monitored on the registry and will be the focus of in-depth specialist analysis going forward. Thank you.